In clinical substance use treatment, screening and assessment operate as related but strictly separate functions. Conflating the two is a common operational error, and it reliably leads to misdiagnoses, inappropriate care assignments, and systemic failures in patient management. Screening is a brief, highly focused process. Its entire purpose is to answer one narrow question: does a problem likely exist? It functions strictly as a sorting mechanism. The clinician uses it to rapidly separate individuals who need a further look from those who do not. Because this initial phase is purely designed to measure risk and check for program appropriateness, a brief screening interaction cannot logically generate a final diagnosis or dictate a treatment plan. When that initial sorting indicates a likely problem, the process shifts to an assessment. This is a significantly broader and deeper investigation. The objective shifts from rapid triage to comprehensive data gathering. The clinician must understand the precise severity of the problem, the specific needs of the patient, and the individual strengths they bring to the table. This side-by-side flowchart illustrates the divergent outputs of the two phases. Screening yields a simple, binary triage decision. Assessment produces the dense contextual data required for formal diagnosis and treatment planning. This distinction defines the clinical workflow. Screening acts as the initial access point, while assessment provides the comprehensive guidance required for long-term intervention. A central rule governs clinical intake based on this relationship. A positive screen mandates a transition into a fuller assessment. It never allows a jump directly to a treatment intervention. Assigning a clinical label or dictating a recovery trajectory based only on triage findings is a procedural failure. Effective treatment requires the full multidimensional perspective that only a comprehensive assessment provides. To function effectively as a gatekeeper, the screening process systematically evaluates signs and symptoms across three specific domains of a patient's life. First is the psychological domain, where counselors look for acute indicators like depression, anxiety, extreme isolation, and unexplained irritability. Next is the social domain, characterized by external disruptions, intense familial conflict, marital estrangement, the imminent threat of job loss, or sudden legal trouble like a DWI. This three-ring Venn diagram shows how the physiological domain overlaps the previous two. Here, the focus is physical evidence, increased tolerance, organ damage, and active withdrawal. Beyond detecting substance use, these overlapping domains help determine programmatic eligibility, confirming if the patient meets specific admission criteria. This includes evaluating overall appropriateness for the setting. A patient presenting with acute medical needs, severe mental illness, or pregnancy often requires an immediate shift to a higher level of care. Any coexisting condition identified during this phase serves as an immediate signal that outside professional referral is necessary before proceeding. The screening counselor relies on these domains to answer two practical questions: what requires a closer look, and has this patient walked through the correct clinical door? Counselors do not rely on intuition to evaluate these domains. They use validated screening instruments to ensure the process is mathematically consistent, efficient, and legally defensible. The CAGE questionnaire is a standard, fast, 4-question screen for alcohol. It is easy to administer, though its sensitivity is limited across diverse populations. The World Health Organization developed the Audit, a 10-item tool, and its 3-item derivative, the Audit-C. Both offer high sensitivity for detecting hazardous drinking patterns. For non-alcohol dependencies, the DAST provides a brief, reliable self-report tool engineered to flag drug-related problems. The SASI, or Substance Abuse Subtle Screening Inventory, takes a different approach. It utilizes unique, subtle scales designed to detect use disorders even when a patient is actively minimizing or denying their behavior. Clinicians also utilize the MAST for longer, deep-dive alcohol screening, the CRAFT, validated for adolescents, and the ASSIST for multi-substance screening. This scatterplot charts tools across two axes: substance focus and sensitivity. The counselor selects the precise instrument matching the client and clinical setting. Administered scores are evaluated against mathematical cutoffs, strictly designed to indicate risk, not issue final verdicts. A breached threshold simply delivers a command to the clinician to look closer. An instrument alone cannot diagnose a severe disorder. When that screening threshold is crossed, the clinic initiates a comprehensive biopsychosocial assessment. This phase maps complex clinical and historical domains. The counselor catalogs specific substances used, usage patterns, age of onset, periods of abstinence, and the patient's full medical and psychiatric history. It charts environmental and personal variables, family history, past trauma, legal status, vocational standing, and the cultural context of the patient's living environment. Compiling this massive volume of data could easily become chaotic. Clinical counselors utilize standardized tools, like the Addiction Severity Index, or ASI, to impose structure on this information. This 7-axis radar chart illustrates how the ASI measures problem severity. Instead of producing a single reductive score, it maps severity across 7 specific standardized domains, ranging from medical and legal to family and psychiatric, creating a precise, multidimensional picture. Despite the volume of data collected, the tone of this interaction is critical. It is conducted as a collaborative process, designed to build clinical rapport and engagement rather than an interrogation. By structuring this holistic life data properly, the biopsychosocial assessment yields the exact multidimensional profile required to write a functional, personalized treatment plan. To be clinically competent, this assessment must be inherently strengths-based rather than strictly problem-focused. While mapping pathology, the counselor must deliberately mine the client's history for existing resources, functional skills, internal motivations, and instances of prior success. Treatment and recovery are built upon the strengths a client already possesses, not upon their deficits. A purely deficit-focused assessment identifies what is broken, but entirely misses the foundational material required to sustain long-term recovery. The final assessment document is not a ledger of everything wrong with the patient. It is an exact inventory of the tools the patient currently holds to achieve their treatment goals. The concept of the intake-only assessment is a clinical myth. Assessment is a continuous process that runs throughout the duration of treatment. As a client progresses, stabilizes, or goes through withdrawal, their clinical picture naturally shifts. Continuous assessment ensures the treatment plan adapts in real time to match the patient's changing reality. This process requires strict cultural responsiveness. The tools and interview styles selected must align with the client's primary language, literacy level, and cultural norms to yield valid data. Interpreting a client's responses through the counselor's own cultural lens, rather than the client's, predictably produces inaccurate clinical findings and actively ruptures the rapport necessary for treatment. Because screening and assessment generate highly sensitive information, the process is bound by strict confidentiality requirements under HIPAA and 42 CFR Part 2. Clinicians have an ethical and legal duty to obtain valid consent and clearly explain the limits of confidentiality to the client. Mishandling this data causes immediate, real-world harm. Finally, assessment enforces scope limits. When the data reveals conditions outside the counselor's purview, like active psychosis or a medical emergency, referring the patient to outside specialists is a demonstration of core competency, not a failure of care. A rigorously executed pipeline from initial triage to ongoing assessment protects the client, defines the precise scope of care, and establishes the necessary foundation for a successful recovery.